Thanks very much. I'd like to thank the organizers for inviting me. I'm going to give a bit of a different perspective, I think, than my co-presenters, because I'm not doing primary research in this area. I actually am the leader of an organization called Optum Labs. We're part of Optum. We're a small group, about 50 people, part of Optum. That's part of United Health Group. And we have the opportunity to have a very substantial data asset, which is somewhat unique, composed of commercial claims data and linked electronic health record data that has tremendous value potentially for the study of high-needs individuals, high-cost, high-needs individuals. I'm going to share with you some just drips and drabs, essentially, as examples of the tools and the approaches that that people are taking with this at Optum Labs. As I said, this isn't my work; it's the work of others. So, Optum Labs is an organization that has that fosters essentially collaboration amongst partners. There are some 20 partners or so, and we have more on the way, who work together sharing electronic health record claims and other data assets, as well as expertise and thought leadership, convene meetings, et cetera, to discuss to work on projects that are involved in improving patient quality and the cost of patient care through discovery, research, translation, and even innovation. So our data, which is what I'm going to talk about today, is composed predominantly of commercial claims data, which is a mix of commercial claims and some Medicare claims of 130 million patients that is linkable, and another 33 million patients that is not linkable, and a very rapidly growing asset of electronic health record data of about 48 million patients. So I'm going to show you a little bit of what can be done with the claims data, and then at a very granular raw data level, show you the kinds of things you can see in electronic health record data. Because from my perspective, what we're looking at today in terms of in terms of research on high needs patients is somewhat of a nebula. It's quite fuzzy. It's like looking at that little cloud in the sky that that is the Andromeda Nebula, if you will, and we need to continue to sharpen that up to get to these subpopulations and categorization of patients. And sometimes when you focus on a nebula, you just get a bunch of clouds. But sometimes when you focus on a nebula, you get a lot of tiny little stars, millions and millions of tiny little stars, and so some of those cluster together. I think that's the place where we need to go. And electronic health record data is a lot closer to those sharper stars in many ways than the claims data, especially when you consider in-hospital data as opposed to out-of-hospital data. And I'll specifically show you examples of that. So we're going to talk about the unique leverage of linked electronic health record data beyond claims data in understanding patients. And our lens is going to be through patients with congestive heart failure, just as a simple example of these patients. So this is claims data alone. This is a map of the markets, Marimekko chart. There's a lot of descriptions of this. And essentially, it's a comorbidity profile from claims data of hospitalized congestive heart failure patients, colored by the annual hospitalization rate. And what you can see is, first of all, those congestive heart failure patients with a single comorbidity or no comorbidity are almost equivalent in number to those with 5 major comorbidities in the standard list of comorbidities. I think these are the top comorbidities. And there are even larger groups of patients with 2 or 3 comorbidities. But interestingly enough, those with 3 or 4 have have in some categories as many hospitalizations as those with 5. But so this is just a simple look at this. This is a tool called, we call natural history of disease, and it's a very, very nice hypothesis generating tool that allows you to look at sort of an odds ratio, a raw odds ratio approach, or a cost approach, and this is a cost approach version of it. Let's see if we actually have a laser here. So what we do is we create a cohort in red of patients with congestive heart failure who are hospitalized at this point. And the cohort in blue are patients who are diagnosed with congestive heart failure. Neither of them had a diagnosis of congestive heart failure prior to this, but are not hospitalized. And you can see at the time of hospitalization, there is a very substantial cost that happens due to the hospitalization. But what's interesting is what happens afterwards. Those that are hospitalized with a diagnosis of congestive heart failure have an ongoing continued increased cost, which in months 4 to 10, which is what's highlighted here, is about a difference between $1,800 per member per month cost versus a $600 per member per month. This is raw. This is not, adjusting for all sorts of various things. But what's interesting is if you take that cost and put it in a box like this, you can then hone in on and identify the specific issues for which in darker red are specifically characteristic of the patients, and I was highlighting kidney and urinary tract infection in that case. So an interesting tool that demonstrates some of the things you can do with claims data. Is another thing we've been doing with claims data is to look at patient clustering. We've taken we've created a model that identifies the patients who are at highest risk of hospitalization and taken the top 10% of them and then used clustering methodologies, machine learning clustering methodologies, to identify clusters. And the clusters here, the balls are sized by the size of the patient population. And you can see this gets at some of the things that others have brought up, that there isn't, that patients with congestive heart failure are in fact quite complex, and that there are these very different, for example, dementia, stroke, and paralysis versus arrhythmia versus diabetes dominated versus CAD dominated, et cetera, that really make up very different clusters that are now being examined for outcomes and for different treatment pathways. So this is the beginning of some work that's been done that's been started by Paul Wallace, who some of you may know, at Optum Labs. So I'm going to now transition into electronic health records, and first of all, highlight those things that are somewhat unique to claims data, which is enrollment data, health service costs, and prescriptions filled, and then unique essentially to or available to both. Available to both, which are visits, diagnosis, procedures, labs, provider, et cetera. And then these things are unique to electronic health records, which is medications, microbiology, patient-reported measures, immunizations, and prescriptions written. The difference between prescriptions written and prescriptions filled is very substantial. And if you take something like hypertension and want to figure out why somebody's not following JNC guidelines, by having both of those in the same patient, you can find out whether it's the doctor or the patient. And then using natural language process, which I'll show you some examples of, you can identify a lot of interesting things. And we use natural language processing to create structured variables that allow you to get things like that are in the chart, like pulmonary function tests, which aren't typically in a structured field, but are actually numeric data, or exercise levels, smoking history, or even subtle things like reason for change of medication and others. And I'll show you some examples. So this is an example of a patient who has been rehospitalized twice. First hospitalization, second hospitalization, third hospitalization, and the level, rather than the limited information you would know, congestive heart failure hospitalization, acute hepatitis hospitalization, heart failure hospitalization, what you really are understanding here is that in this hospitalization, their estimated GFR fell very substantially and then started to rise. This is their blood pressure level. And in the second hospitalization, which was for acute hepatitis, presumably, I would guess from some medication, they had a substantial drop in their liver function tests with an improvement and continued improvement of their GFR. And then their BNP was very high in this third hospitalization. So the level of granular information you can get that you can then use for a better understanding of these patients is very substantial. Another example is medications, which you don't see at all. They're not outpatient records, so you don't see in claims data. And in hospital, you can actually see it to the level where you can understand that somebody here converted from from IV to oral Lasix, for example, or had a procedure such as an ablation for dysrhythmia and started medications prior to that ablation and medications afterwards. This is a level of detail that allows you to really understand much more about the patient. In addition, in terms of mining data for natural language processing, here's another patient with 3 readmissions, month 1, month 2, month 3, and you can see the level of detail that you can get in understanding the course of the patient's description as included in notes of physicians and notes of nurses and in pathology notes, et cetera, can get you at a level of very, very substantial understanding. So how has some of this data been used? I'll just talk about a predictive model that I helped develop when I was at Humedica that's been put into use by Aurora Healthcare, published at a lot of detail here that actually gets at some of the specifics of care models and things that many of you may be interested in. Specifically, but what we did is we developed a congestive heart failure predictive model. And in fact, it's very hard to develop a predictive model with congestive heart failure. With claims data alone, it's really inadequate. And we were looking at the risk of hospitalization in a 6-month period for patients and focused in on the highest risk population, which was those with a 95% in the 95th percentile. And we used things like PO2, lab results, vital signs, which in addition to other claims data and other information about prior health utilization, et cetera, to create a predictive model. And Aurora Healthcare actually focused in on those patients, brought them in, and didn't treat the model. They treated the patient by understanding the issues and the opportunities, and were able to reduce heart failure admissions by 65% from the prior year. They actually have, and this has been repeated in other institutions. They took a second model in COPD where they were able to reduce all cause admissions by 20% and had major effects that reverberated through the healthcare system. So by using some of this data that's available in electronic health records, you can get at a much more granular, in-depth look at the patients and better understand them. You still need to create a system that is necessary for the treatment of them, and that's beyond what I really am discussing, but is mentioned in that presentation that I linked to. So finally, looking at electronic health record data and claims data and managing unique populations, laboratory some of the clinical findings that aren't available in claims, laboratory values, radiology findings, clinical measurements, vital signs, smoking status, race, ethnicity, et cetera, pre-adjudicated diagnosis and procedure information. So this is what's submitted by the, and problem lists that's submitted by the institutions rather than just what is accepted and paid. And this is really important in hospital where the list of diagnoses might be this long in what happened, what you can find in an electronic health record, but because claims really are only paid on the, on the highest and most complex, it might only be about this long, and there's a huge difference between claims and electronic health records in hospital. And then temporal details, medication delivery in hospital, and clinical notes can give you a tremendous amount of detail that isn't otherwise available. So thank you very much for your attention. I appreciate it.